2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami, Florida, sunny Miami, Florida. Today we have another in the series of Neurosurgical TV Hangouts. And today we have the pleasure of having Carlos Llumiguano MD, a neurosurgeon from originally from Spain, but now in Ecuador. And today Carlos is going to talk about awake craniotomy. Sounds like a very interesting topic. I'm looking forward to it. And today we have on our panel the right distinguished Simon. Hello, Simon.
Hello. Thank you very much. Always a pleasure to be here. I'm in Tokyo, Japan. I'm a med student and clinical psychologist. Thank you very much.
And welcome, Simon. Okay, Carlos, welcome, and the show's yours.
Good afternoon for everybody. Today we will speak about awake craniotomy protocol for brain gliomas. As an important thing and especially part of neuro-oncology for tumors in a neural center of the brain. And we need to know about what to do in case of if we have lesions located in or near eloquent areas, such as in speech, language, visual centers, or motor sensory areas. What we will do, what is the prognostic factors that we will be waiting for after this kind of surgery. We need about the risks, maybe a permanent deficits of language, maybe a deficits of speech or motor or sensory function in the patients, in some case when the patients present some tumoral lesions in the eloquent areas of the brain. And for that, we had an protocol techniques like an awake craniotomy. Sometimes what we will do in some case when the patient has some lesions in the eloquent areas, we wait and see until the tumor causes some neurological deficits, or we can do it in a biopsy, and after that we can do a radiotherapy or a chemotherapy, or we can choose for the surgery procedures and which kind of surgery we can do it under general anesthesia, or an awake craniotomy or awake surgery in one, or can do it. So when we're doing an awake craniotomy, will be that what is this? The awake craniotomy is an old techniques that is in Renaissance. In 1920, about Penfield doing an epilepsy treatment. After that, Penfield and Pasquet described the surgical and anesthetics aspects of these kinds of surgery. Due to improvements in anesthesia techniques, development in neuroimaging techniques, and development in neuromonitoring techniques, the awake craniotomy at this time had a very high procedures, very high techniques, very high quality of results for these kinds of surgery. We need to know about a awake craniotomy protocol. It's important to know the anatomic of motor cortex in this kinds of patients. The structure of the brain is well studied from the beginning when is starting the neurosurgery techniques. In these kinds, the first doctors or the first investigators who study very well the anatomical structure of the brain was Paul Broca, who was a surgeon neurologist who studied some lesions or some injuries in the brain and what kind of neurological deficits produce these kinds of changes in the brain structure. So the way craniotomy going to development during the past years, we have Foster, Penfield, or Ogeman who are they doing an epilepsy surgery, Rule and Effling who are principal doing an oncological surgery. The most important representatives is Berger, Hackland in the USA, and this kind of surgery at this time we are doing around the world. The way craniotomy can be used in epilepsy surgery, oncological surgery, and in the day brain stimulation principle. But we can use in carotid artery endarterectomy, in some kinds of pain treatment procedures, or in some kinds of peripheral nerve surgery too. The most important thing is that the main indication for a wave craniotomy is to operate near or of eloquent areas. We can do it in a cerebral biopsy. Some tests of treatment modalities like deep brain stimulation, peripheral nerve stimulation, motor cortex stimulation, or spinal cord stimulations. So we can do with these kinds of procedures. The people will be in a shorter time or a shorter hospital stay. In one study that is published in 2007, speaks about all craniotomies do it for celebrities and who are doing a prospective study of a wave craniotomy used routinely and non-selective for supratentorial tumors. In this group, they doing surgeries with the patient in a awake situation, but for all kinds of brain tumors, not just for the tumors located in the eloquent brain areas. So the objectives of the wave craniotomy is an assessment and identification of the functional neurological outcome of the patient with lesions in eloquent brain areas, and further, a pre- and post-operative assessment of language function in patients in whom surgical resection area includes or is close to language areas. Detection and assessment of patients at risk for post-operative aphasia, reduced to minimum functional impairments at 6 weeks of post-operative period. What we need for this kind of surgery, we need a good team, an experienced team with experienced neurosurgeon, anesthesiologist, shipping neuroanesthesia, neuropsychologist, neurophysiologist, and a surgical nurse and nursing team. What we need in a patient who cooperate, training for comparison to the patient. We need a patient with high hemodynamic stability and a secure airway, patient on alert, and we need to ensure for the patient an adequate analgesia and sedation. And we need an environment that is comfortable lying for the position for the patient. We need to regulate the temperature. We need to look for the noise for the patient that will be alterate this nodding. And for all things, we need to have an excellent communication with the patient. During the intraoperative monitoring, we will reduce a routine monitoring for the patient like a blood pressure, but a respiration, a pulse oximeter, but we will need to monitor the blood pressure of the patient, the BIS monitor. We need to control the diuresis of the patient. And it's important to see what is adjustable operating room table to ensure the patient comfort. What kind of anesthesia is good for them? local anesthesia and scalp blockade, and ensure an adequate sedation and analgesia. But it's important to think we need to maintain a communication with the patient and ensure their comfort. In this picture, we can see what kind of points we are used for the administration of the local anesthesia, like a great occipital nerve and a small occipital nerve, an auriculotemporal nerve, zygomatic temporal nerve, and a supraorbital nerve or a supratrochlear nerve. So we can have so many possibilities to ensure the analgesia for the patient in these kinds of surgery. What kind of drugs we can use or we need to use in these kinds of procedures? And a local anesthesia, there be short and long-acting agents with or without epinephrine. What's about the cardiac toxicity for these drugs? What is the umbral shots of the seizures? So we must know that, for example, propofol decrease the potential of the seizures. In this table, we can show that local anesthetics and time and doses that we are using in these kinds of surgery. In our case, we always use a lidocaine and bupivacaine because they can give us some security to management of the patient analgesia.
Yeah, sure. Okay, I won't talk. I muted my microphone though. So who's on the screen?
During
you'll tell me. Okay.
Craniotomy, in the intraoperative neuromonitorization, we have two objectives. Is to help to provide basic, advanced, and fast monitoring for certain neurological functions at risk during surgical procedures, and we must to know the change in neurophysiological response should alert the surgical team to make adjustments that can reduce postoperative deficits. What will we do as a neurosurgeon? We need a neurosurgeon who believes in the neurophysiological monitoring, who understands and knows the limitation of neuromonitorization, who know the correct monitoring of each surgical types, who understand the causes of signal change, and who ready to act appropriately in some case of change during the surgical procedure. We need an anesthesiologist who check the position and possible nerve compression, checking and increase the blood pressure, check anesthetic agents and can convert to a total TIVA, who optimize the hemoglobin of the patient, who use an muscle relaxants as shown for the case, who optimize the temperature of the patient and the environment in the OR. We need a neurophysiologist who has an intraoperative neurophysiological experience, who know the type of surgery and anesthesia, who has an ability to differentiate and find solutions to the surgical, technical, physiological, and pharmacological changes, who has a good communication with the surgical team, and really available in the operating room. We need a neuropsychologist who be familiar with the OR, who have a good technical knowledge of the neuropsychological tests that will be doing pre and in intraoperative conditions. And it's very important to recalculate that they need to have a good communication skills with the patient and the surgical team. So, what kind of electrical stimulation we can use during these kinds of procedures? We will have an excitatory phenomenon, like a sensory or motor cortex, or visual cortex, or auditive cortex stimulation. And we can use an inhibitory phenomenon when we analyze the language, the memory, and higher cognitive functions in all patients that we are doing the awake craniotomy. So, like in these features, we can give in sometimes some electrical stimulations. What kind of stimulation we are using, when we are giving the stimulation for the patient, and how will interpret the patient these kinds of stimulus. So, with this kind of stimulations, we can prove, we can research the surgical or technical defects that will be provoked in some kinds of patients. Even it's important to see that in this proper manner we can evaluate the language areas in the patient. So we can use the intraoperative neuromonitorization with cortical or subcortical stimulations we use for identificate the central sulcus and motor area in the patients. You can see in this picture how we can put the electrodes for monitorization in the length picture. We can see how to analyze, how to see, to determine the central sulcus in these kinds of patients. In the other kind, we see how to doing a subcortical stimulations in these kinds of patients. So, the cortical mapping key points is a gold standard. It is a real predictor of functional outcome. This procedure is used to map in the brain by applying a current directly to the cerebral cortex by inducing temporal and localized activation of disruption of some areas. Yet, cortical mapping varies according to the studies, according to the institutions. So, we have so many protocols that will be unified in the next years, maybe. We doing an intraoperative cortical mapping with under general anesthesia. We can mapping with the motor evoked potentials or somatosensory evoked potentials. During awake craniotomy, we are doing a stimulation of one area of the cerebral cortex, and we will analyze the verbal, the responses, movement responses, or we can analyze the emotions and sensations that will be experienced for the patients. We can do an speech testing, so we can identify the broadcast area by inducing speech arrest. We can identify other cortical language areas by reading and words compressions in the case of Wernicke area. We can analyze all the data presented or performed by the patients. This will be very difficult in the case of polyglot patients when we will have so many language centers specifically for the understand and comprehensions of the words. We can see during language and speech locations some kinds of language areas and multiple within in the craniotomy. The distribution beyond the area of Broca and Wernicke, in so many cases they have in a mosaic distribution. The size of these kinds of language areas will be in 1 or 2 quadrat centimeters. In the first 50% are separated. They will be localized in parietal, temporal, lobe, and frontal cortex. In so many cases, before the surgery, we can identify the critical language areas with PET or with functional MRI in some cases. Which is the indications, which is the criteria of selection for patients who will be under awake craniotomy? Tumors, or patients with tumors adjacent to eloquent areas, example left peri-insular tumors. Patients with tumors in presentral gyrus can be monitored either under anesthesia as well. Patients who had an recurrent or untreated lesions near or within the supposed language area, maybe in Broca or Wernicke areas. Patients who are between 15 and 70 years and be fluent and comprehension the language. If it's Spanish or if it is English, so we must ensure that we will do these kinds of evaluations in the mother language of the patients. The patient may be mentally oriented, and there will be no severe aphasia before the surgery in these patients. The absolute or the exclusion criteria are sleep apnea, maybe in this case of obstructive sleep apnea, the patients who had a claustrophobia, patients with dementia. Some relative exclusion criteria are epilepsy, refractory to drug treatment, or patients with airways of difficult access. What kind of complications we will be had with these patients? Seizures, or we need to convert to general anesthesia, respiratory depression, airway obstruction, oxygen saturation decrease, arterial hypertension or hypotension, nausea and vomiting, pulmonary aspiration, air embolism, pain, and other complications that will be used. And it is important to see what's about the patient's satisfaction or dissatisfaction during the surgical procedure. In some cases, feel the need or sensation to urine, feeling the cold, dry lips, itching of the nose. And for other side, we must know what kind of studies or imaging studies need the patients before the surgery. We need an MRI compatible with neuronavigation. About our protocol is an empty-reach axial slice for 0.8 millimeter thickness. In some cases, we can use MRI studies with diffusion and or functional MRI, and this image we can fuse with a routine MRI empty-reach axial slices. What about neuro-linguistic evaluation? In the pre and top, we need to do a pre and post-operative assessment. Formal neuro-linguistic tests performed once pre-operatively and twice post-operatively. We use an Achner aphasia test that they have 5 sub-tests handling test to identify and manipulate geometric shapes after a verbal command. Repetition test consists of phenomena, words, and sentence repetition. Writing language test is to read and write. Visual naming test and understanding test that we'll use in this case of patients. In each of the subtests, errors will be classified as known, minimal, discrete, moderate, or severe deficits according to the rules of the Ashner-Absan test. And the postoperative patient information training. At least 3 days before surgery, patients should be informed in detail about the process of intraoperative monitoring, about electrical stimulations by the responsible for the intraoperatives individually and the appropriate time. These kinds of tests that will be explained by the neurosurgeon and the neurophysiologist. The patient should be familiar with the material used for stimulation or trying to perform the test during the surgery. So, we need to have an overall assessment. We need to establish a good relationship with the patient. We need to inform the patient about all stages of the surgery. We need to control of the drugs, especially anticonvulsivants. Obese patients may be a great challenge for these kinds of surgery. It is important to speak about the patient position. The main objective of the correct positioning is to increase the comfort of the patient, to reduce the intraoperative stress and anxiety, to allow the correct visualization of present stimuli and comply with the requirements of the surgeon. After positioning the patient and disinfection of the surgical area, local anesthetic is injected at the site of a scanning incision before supraorbital area, zygomatic arc, and the retroauricular area. So, we will have during the anesthetic techniques and a pre-medication regards of the type of anesthesia. We'll have a basic monitoring, and we need to do a bladder catheterization given the duration of the surgical procedure and the possibility of using osmotic diuretic during the surgery. We can do it on a total awake craniotomy, like with local anesthesia associated with conscious sedation, or we can do it on a sleep, asleep, wake, sleep craniotomy. General anesthesia with intraoperative wakefulness, commonly referred in the literature. So, this is the picture in which, before we presented that, which of the cranial nerve we can blockade during this kind of surgery: auriculotemporal nerve, zygomatic temporal nerve, supraorbital nerve, supratrochlear nerve, smaller occipital nerve, greater occipital nerve, or meningeus block. So we can use these kinds of nerves to block and to ensure for the patient this really anesthesia. So during the general anesthesia with intraoperative wakefulness, when we are doing an asleep 8-week sleep craniotomy, we have an asleep period, start infusion with rimifentanil, infiltration with the local anesthetics. After that, we can fixing the head of patient. After doing with a craniotomy, after that, the dura opening. After that, we will have an awake period for the patients. We will maintain the sedation with rimifentanil, And during this time, we can use an cortical mapping, subcortical mapping for the patient, and during this period, we will end the lesional resection. After that, the patient will be again to the asleep period. For electrical stimulation, we have two possibilities, such as a monopolar stimulation and bipolar stimulation, but always we are doing with a parallel electrographical or electrocorticographic monitorization for doing a continuous monitoring of the brain activity. When we are using or mapping the with a monopolar stimulation, the stimulation parameters are stimulate trains of 5, 7 with another stimulation. The intensity will be between 2 and 16 milliamperes with a frequency of 250 Hertz and the duration of 0.1 or 1 milliseconds. The advantage is mainly the risk of crisis is very low in these kinds of stimulation, is less than 1.8%. And also you can get an EMG response, so you can measure the amplitude and latency of the response and compare with the previous one. The disadvantage are the monopolar stimulation is that is less focal stimulation with bipolar and cannot be performed a language mapping with this kind of stimulation. With bipolar stimulation mapping, a bipolar stimulator with an interelectrode distance of 5 millimeters, the stimulation involves trains of 5 seconds duration with a starting intensity of 2 milliamperes and increasing at 2 milliamperes. The duration of 200 and 500 milliseconds and frequency of 50 to 60 Hertz. So, with this kind of stimulation, we can evaluate an area will be considered eloquent if the patient has movement or has an error of language consistent of at least 3 separate trials. We can decide what is the mapping of threshold, the post-discharge threshold. The main advantage is that bipolar stimulation is more focal and can map the language area because the stimuli during 5-7 seconds. And the major disadvantage is the risk of seizures is higher. It's about 10 to 25%. We need to have, or we need to use a concomitant electrical corticography. In so many cases, use a tonic muscle contraction making. It's very difficult to measure and compare with the response to the previous studies. So, electrical corticography monitorization used to monitor the brain activity of patients continuously, searching for the presence of post-discharge activity in the presence of clinical signs of surgery. So, we will do it on a language test like a visual naming test, word generation test, and understanding sentence test. These tests should be performed 3 days before and after surgery within 21 days and 1 year after the surgery. We will be used for the visual naming test, especially this test is a Rubius activator for the essential and not essential language cortex, special broadcast area. So we will stimulate the broadcast area with this kind of stimulus in the patient. With the word generation test is to a Rubius activator of the frontal language areas, and also will be activate the language areas on the frontal lobe. So the patient will be to give, to see, some words, some numbers during the surgery, the patient should be known some pictures that will be present to the patient during the surgical procedures. And the understanding sentence, patients are presented with the two identical phrases at all except for one word that is replaced by a synonym or a different word. They should listen to this pair of sentences and decide which of the two has a literal meaning. This test is a potent activator of the brain regions that involve semantic processing located near the perisylvian cortex. And a postoperative management of the patients. We need to have a control of blood pressure, fluid, electrolyte, level of consciousness. We need to maintain an antiemetics and prophylactic anticonvulsivants. We need to continue with the analgesics. If we have some complications such as infection, seizures, neurological dysfunction, bleeding, cerebral edema, or intracranial pressure monitor increasing signs, we need to do an cranial CT to have some kinds of, or to evaluate some kinds of change in brain structure. During 2008 and 2014, during my work in Spain, we are doing a neuropathologically controlled tumor resection radical in 80% in 39 patients, and tumor resection under permanent functional control. Histopathologically, in this case, was cavernoma in 2 cases, astrocytoma grade 2 and 7 cases, astrocytoma grade 3 and 8, oligodendroglioma 3, glioma or glioblastoma in 13 patients, DNET in 2 patients, meningioma in 7 patients, and metastasis in 13 patients. Accordingly to the localization of the injured was prefrontal and precentral in 20 cases, central in 7 cases, temporal 7, temporoparietal 9, and temporooccipital cases 5. We did not have any kinds of complications, and activity daily life independent 6 months after surgery in these kinds of patients was 100%. We had 48 patients. The hospitalizations average was 5 days. 2 patients, last 10% was 7 days. In which patient was the patient was in hospital more than 10 days. The complications was minimal. So maybe we can see how we doing so you can see how are doing these kinds of procedures when the patient is awake, the patient doing all kinds of tasks that we are asked to him. And during the surgical procedure, we always monitoring not just a physiological change, we analyze the motor function, language function for the patients. So this is the intraoperative neuromonitorization. This is an airway craniotomy in some cases of patients with tumors in the eloquent area. Thank you very much.
Thank you very much. That's speech.
Yeah, thank you, Carlos, for an excellent, well-illustrated presentation. Wow, that was great. That was great. And I'll ask Simon or Ben if they have any questions.
Yeah, I almost feel like I'm ready to.
Simon, just 1 minute. Let me introduce someone before we start. And I'd like to introduce Ed Walter Johansson. He's a lawyer from California, and I want Carlos to meet him after the hangout because we're trying to, Ed and I are going to try to put together a series of televised conferences on traumatic brain injury as well as other topics. Hello, Ed.
Hello. Hello, everybody. Yes, as John mentioned, we are setting up the Brain Injury Research and Education Network, and it'll involve a number of institutions in the U.S., including, I don't know if including Stanford VA, Stanford University, UCLA, Walter Reed, let me get on here, Walter Reed Hospital, and Brooke Army Medical Center. And it'll be very exciting how we include these. And then the network we use will record it, and it'll be on, where I'm going to give the recording to John Bennett, and he's going to distribute it on his Google Hangout. So I think you'll all excited. Anybody have any questions that I could answer?
Okay, well, we can talk later about that, and we'll continue with this presentation, and then we'll talk later.
Okay, I'm going to I have to get back to work, John. I'm working today.
Okay, okay, Ed, we'll talk to you later.
Thank you.
Nice seeing everybody. Bye.
Thank you.
Okay, yeah, Carlos, I want you to quickly meet Ed because you may be part. He's done a lot of video with big institutions, and he may want to have hangouts as part of that. And of course, you'll be part of that too, Carlos. So, Simon and Ben, do you have any questions of that excellent presentation?
Yes, please, if I may go first. Thank you very much for your presentation. Last week I was watching a awake craniotomy in a patient who had a glioma, and I was fascinated. But I was wondering regarding the patient training. How long does the patient training take?
Hello, Simon. In these kinds of patients, we have to. In the first time, we need to do it in a good selection for the patient, and the second time, the preparation of these kinds of patients, they will be at least 2 weeks.
I see. It takes a long time to prepare.
Yeah, because these kinds of patients had some kind of many sessions with the neuropsychologist, because the neuropsychologist is working with patients before, during, and after the surgery. So so many people, so many centers can do it on an airway craniotomy, but our center, our protocol is that the neuropsychologist must work with the patients for at least 2 weeks before the surgery and to prepare the patients all about the change during the surgery.
Oh, I thought it was just 2 weeks before, but they continually, like every day for 2 weeks. They need a lot of practice, so it's crucial, I imagine. And I'm wondering, in general, would you be more likely to be doing surgeries in the Broca area or the Wernicke's area? Which one is more common? I don't know if they're equally.
I think we need to, for example, in many cases, the brain gliomas, for example, in the glioma cases, they are situated more frequently in the areas of temporal-parietal lobe, and in these cases, the Wernicke areas will be more affected in these kinds of cases. But in the frontal lobe, where is located the Broca's area, it is not any frequent like in a temporal lobe. In these cases, it's more the change of the lesions will be in a low-grade astrocytoma or in some cases it will be on a metastatic change, or maybe on a vessels malformation that will be situated there.
Wow, I see. Thank you very much. My last question is regarding, you mentioned that obese patients are a challenge. I wonder, why are obese patients a challenge in this type of surgery?
Because during these procedures, so many parameters will be changed. So what's about the blood pressure? What's about the oxygen saturations for these patients? And it's very difficult to do with these patients if the patients will have some stress for the surgery. And this will be very, very difficult to manage of these kinds of patients. But this is like this is not an exclusion criteria, but we need to know about these patients, and we will to prepare. Not just the patients. We must we must prepare for us too, because what about the neuropsychologists? What about with the neurophysiologists? What about the anesthetics? What about the surgeon too?
Wow, many things.
Okay.
Thank you.
Very good. Ben, do you have questions?
Yeah, I have a lot of questions actually. Thank you very much for this great presentation, Dr. Carlos. I think it's basically, I believe it's an elective procedure, right?
Because yeah.
It's because you can't, do it as an emergency, because you have to prepare and you have to have all those teams. And I also think that it's an expensive procedure. Like, you got to have all this staff inside the room. Everybody has to monitor, and neuropsychologist on one hand, neurophysiologist, and pharmacologist, maybe so many people around. You need a big team for this kind of, to keep the patient awake.
Yeah.
And also you mentioned like there are some unexpected complications, like all of a sudden the patient gets neurotic or something, he gets upset, or that's really hard to manage in that situation. And I heard that, I was reading that there's a medication called dextromethorphan, something like that. In addition, with propofol can enhance this procedure.
Yeah. So I told during my presentation that we have two techniques of awake craniotomy. Once an awake asleep craniotomy, when the patients are sedated, and after awake, and after another time sedated patient. This kinds of we can use the propofol. Propofol sedated patients with a very low doses of propofol. And the other kind is when we are doing just a totally awake craniotomy. In this case, any kind of sedation we didn't use. So I know this is these kinds of techniques that we can't do it in any hospitals, in any centers, because it's a very, very expensive procedure.
Okay.
Because we need a lot of our resources. We need to not just economics resources. We need to professionals. We need to neurosurgeon. We need a neuropsychologist. The neuropsychologist is a very right profession in medicine. But it's very difficult to have a neuropsychologist, and after a good neurophysiologist who had experience in where it's very difficult to have.
And how frequently you might see these kind of patients, like when you're doing these kind of procedures, how frequently you kind of face these situations, like patients.
Sorry, can you repeat, please?
How frequently you faced with these kind of situations, like patients getting agitated or getting upset during the surgery, despite you prepare the patient?
During our
in your experience.
in my experience, I didn't see any kinds of complications during the procedure. But I think I have a good luck because I know that always we will have some kinds of complications. Always.
Yeah.
We are not exempt. But at this time, I do it 55 patients at this time. I didn't have any kinds of complications or change during the surgery, after the surgery, but I think I am a good people. But I am waiting. But maybe, yeah.
Yeah, that's right. Thank you.
Going along with Ben's question about being elective, do some patients, are they kind of scared of it? I mean, being awake during this, or do you sedate them, or how does that work? Or patients kind of welcome it and they say, okay, no problem.
No, so for when we have some patients with some lesions in eloquent areas, or maybe important if we will be see after surgery with a great neurological deficit, we must to speak with the patients. Okay. And we will to explain to the patient and see and to explain what is about the surgery, right. what's about the perspective, what's the prognostic things in this case. Because we can speak with the patient and say, what do you like if after surgery you will be had so many difficulties? Maybe you can't speak. Well, maybe you can speak, but you can't, or you didn't understand what the people say to you, or if you, after surgery you will not be able to walk, or will not be able to do a song with your hands. But we have techniques when the patient can stay awake during the surgery, and we can analyze and we can monitorize the patient and see what kind of change will we have during the surgery, and we can see and we can do it and say stop, no more. Here is the best. So we need to speak with the patients very well, and at this time when we are selecting one patient for this kind of surgery, any patients can be refused these kinds of techniques.
Okay, thank you. Any more questions, Simon or Ben? Simon?
I mean, based on the cost that you're putting into the patient's procedure and also the results that you're expecting, compared to both.
Yeah, when we speak to the patient, always we speak about the expected results. What will be beginning, what will be arrive with these kinds of surgery. So always, if you are speaking with the patients, after you explain to the patients about the things, and you would receive what will be the expected results, the patient will be clear with this.
Right.
We didn't give to a false expectative things for these kinds of patients. Because this is the frequently the things that the patient after the surgery will have so many problems. But when you explain it very well for the patients, and this will be a good relation if you have very compliance with the patient.
Okay.
Very good.
I have one last question.
Go ahead, Simon.
Sorry, just I imagine the training of the neurosurgeons in how to do this procedure is quite complicated and takes a long time. To what extent could you do that type of training long distance? Like if you were talking with a neurosurgeon in another part of the world and you were trying to explain how to do it step by step, could you do some of it online?
I think the people or the neurosurgeons who will be do it on these kinds of surgeries, they must study in the first time the physiological change, psychological change, and they will be not very well on a neuroanatomy things. So after the neurosurgical preparation for these patients, and we need, for example, 4 or 5 years to good and a good experience. Beginning in my case, I was beginning my techniques when in 1998, when beginning with my teacher to do a functional neurosurgery, start stereotactic surgery, and after and doing other times of preparation, I was doing a microsurgery, microanatomy preparation. So I think is minimally for 4 or 5 years, and after that, we never ended our preparation, our study.
Okay, thank you.
Very good. Thank you very much, Carlos. Excellent presentation. Very clear. The slides were excellent. And thanks for coming out. And we'll talk after. And thanks, Ben and Simon, for coming out. And we'll see you at the next episode of Neurosurgical TV.
Sure.
Adios.